in UCLA, LA. So he'll be talking about CT and radiation dose in children.
Good morning. I will talk today about the more technical aspects of CT and radiation dose in children, following Dr. Goski's introduction. And we all know that CT is a fabulous modality, and since it was first invented 20 or so years ago, the first cross-sectional imaging with radiation, it has made a tremendous progress. From the first AMI scanner to what we can do now with dual-source multi-detector CT in just one breath hold and one heartbeat for cardiac CT. But because of the success of CT, the numbers keep going up all over the world. And this is just a slide for the United States. 93 million CT scans per year, most of them in the Western world, but increasingly also in developing nations. These are estimates of the amount of the percentage of examinations in 1999 that were done by CT. 4% of all radiology examination, accounting for 40% of the dose, and currently that has doubled. 80% of all the medical radiation doses from CT. Global activity of CT scanners. United States has one of the highest density of scanners per population and procedures per 1,000. Distinctly lower in Europe, and I believe in Brazil it's probably also lower, but it will be going up. So in the United States the market is pretty much saturated with CT scans, but in other parts of the world it will continue to go up because of the successes of CT. The bioeffects of radiation are all known to us. Ionization leads to breaks of the DNA. There's some repair mechanisms going on that are the basis for the so-called hormesis theory that states that lower-level radiation could be good for you. But these repair mechanisms could be overcome, and there are several effects. The deterministic effects, the effect is directly proportional to the dose, with a threshold, and we're talking about cataracts and skin burns over 200 rad. And what we're talking about mainly here is the stochastic risk. The risk is proportional to the dose, but the effect is independent of the dose, and there's presumed to be no threshold, such as cancer induction and genetic damage. We have support in epidemiological studies, the most important one being the Hiroshima A-bomb survivor cohort, irradiation for benign diseases such as thyroid, thymus, and skin disorders, and secondary malignancies after radiation treatment, epidemiological studies of people who had undergone fluoroscopy for tuberculosis, postpartum mastitis, and scoliosis films associated with a higher incidence of breast cancer. Even ordinary X-rays, more than 2 have been associated with a slightly higher and significant risk increase in leukemia, and in utero radiation also increased risk of childhood cancer and leukemia. So this has led to the important paper of Dr. Brenner and Hall in the AJR, and then this was also taken over by the lay press in USA Today, and after that we got so many questions to answer from concerned parents. What does it mean? 725 excess cancer deaths per year in the United States. This has to be put in its perspective, of course. We're still arguing about the dose response curves in the literature, and the linear curve is the one that most people adhere to. Excess risk varies linearly, even in lowest doses it goes to the 0, and there is no threshold there. Other people argue that there may be a threshold there, and some people believe it's a linear quadratic response curve. So this is still a hotly debated area in radiobiology, and we will probably not nearly in the next 10 years know the answer to this. This is a slide from the Brenner article that suggests at least that there are statistically significant increases in excess cancer induction, and you can see that these arrow bars are statistically significant even at low doses that overlap with diagnostic CT scanning in children. And it also suggests that there may be a supralinear dose response in the low dose range. Now, we all know that children have absorbed higher doses of radiation. These are the organ doses for fixed settings of head CT and abdominal CT at lower ages, higher absorbed doses. It's a physical principle that is well known to physicists. Children absorb higher doses. They're also more sensitive, and in particular, girls are more sensitive than boys. And the younger they are, the more sensitive they are. Effective dose, the effect of the dose on the whole body is higher when the exposure is an area where there are a lot of radiosensitive organs, so that's in the abdomen, as opposed to the head where there's few radiosensitive organs. So why is this now an important topic? New data coming out every now and again from biological effect of ionizing radiation committees. And each time they come up with another report, they double the risk estimates. And now the risk for children for cancer induction is estimated at 1 in 550 per CT scan, and higher in women. Warnings have been issued by the government, FDA, National Cancer Institute, to limit pediatric CT use, and the Department of Health and Human Services in the United States, a government organization, has designated radiation officially as a carcinogen, and I think that is a huge deal. When a government organization says that there's something there, we have to take this very seriously. So basic assumptions that most people use is that cancer risk, empirically scaled down from and are known from the Hiroshima data, and scaled down to low dose range, and that there is a linear no threshold model to be used, which simplifies the calculation. It's most suitable for population studies. It's not suitable for individual dose measurements, but it's supported by most of the literature in radiobiology, adopted also by regulation agencies. It's hard to understand and have a feel for how much radiation it really is, and sometimes I find it easier to express the dose of CT scans in number of chest X-rays or days and years of background radiation, as is done in this slide, and that helps to convey what we mean to our referring physicians. So in chest CT equals 400 chest X-rays or 2.7 years of natural background radiation. Well, if you talk about risk, everybody runs risk in daily life, and we need to put this in the proper perspective. Smoking cigarettes is risky. It cuts 6 years out of your life expectancy. Being overweight by 15%, 2 years less life. Having a glass of wine every day, most people do it, but presumably it will cost you one year of your life, the average consumption of US alcohol. And accidents, 207 days lost. All natural hazards, such as hurricanes and volcanic eruptions and tsunamis, only 7 days of life cut. Background radiation, only 18 days. We cannot avoid it. You know, we're all exposed to this. An occupational dose that we all can have every year cuts 15 days out of our life. We have been a very safe profession. And these are the various occupational risks. In all industries, 60 days lost, but agriculture, farmers, 320 days lost. Construction work, risky. Mining, quite risky. Manufacturing, not so risky. And being a radiologist is not very risky. So if you turn these figures around, you can say 1 CT, 10 millisieverts, can equal to the smoking of 140 cigarettes, 4,000 tablespoons of peanut butter. Don't know where that comes from. I think it has to do with anaphylactic reactions. 200 days of living in New York City for air pollution. 4,000 miles of driving in a car. Nobody thinks twice about getting in a car in the morning to go to work. People feel they are in control, but people worry more about flying in an airplane. It's much safer, obviously, to fly in an airplane than sit in your own car. And then 300 coast-to-coast flights for the amount of cosmic radiation, and 10 hours of canoeing. So we run risk in everyday life. We take on risk voluntarily, and how do we compare that with medical risk from CT? And this can be applied to a CT angiogram for pulmonary embolus, which has a fairly high radiation dose, as we know. Over 1,000 chest radiographs, 22 mammograms, 7 years of background radiation, the smoking of a good number of cigarettes, 8,000 miles drive in a car, 500,000 miles of jet travel, and so on and so forth, canoeing and tablespoons of peanut butter. So what does it mean? It is a way of, it's a mathematical equation. It's what does it mean to people? How do we estimate this? How do we convey this to people in terms of consenting people? Of course, we want to cut the number of unnecessary CT scans, such as in the CTA's protocol of the chest. We don't have to do a pelvic runoff, as I do in the adult CTs, to look for DVT in the pelvic veins. A risk in 1 in a million is usually ignored by most people. A risk in 1 in 100 occupational death is considered unacceptable by agencies that oversee occupational health. A risk in 1 of 1,000, the presumed CT radiation risk, may be accepted if the individual knew of the risk. In other words, there's some form of informed consent, and that's very difficult to obtain, received at least some benefit and understood that dose optimization has been applied. This is a typical clinical scenario. A 10-month-old that arrives in an emergency room with head trauma easily gets a number of, when there's a real head trauma with an injury to the brain, patient gets a number of CT scans, with follow-up of the lesion. I want to emphasize, even though the brain is not very radiosensitive, there is a paper that says that there is a link between cranial radiation and a cognitive deficit, which is based on comparisons with irradiation for hemangiomas out of Sweden. And usually the scan is continued for a cervical spine, CT, and this has been linked to a 14-fold increase in estimate of thyroid cancer induction by substituting the plain film series for the so-called low-dose CT scan. And we all know that there may be lesions in the cervical spine that have no radiographic abnormalities. So do we continue the scan to the whole chest, abdomen, and pelvis? That really depends on the clinical indication. And it's not routinely recommended in every patient, as is often done in many emergency rooms. Also, misconceptions about disease. An adult radiologist had difficulty interpreting this radiograph in a patient with fever and thought there may be a retropharyngeal abscess there. CT scan was done for this reason and it was found to be normal. So this is probably not indicated if people know what the normal variants of pediatric disease look like. ALARA principle dictates that we should use age and weight adjusted pediatric reduced dose protocols. Determine whether the CT is necessary or can be replaced by conventional radiography, ultrasound, or MRI. Generally, there's no need for pre-contrast scanning or multi-phase exams in children. And to avoid unnecessary repeat studies. So what do we know about the effect of how can we as radiologists improve our practice to lower the radiation dose? And these are just polling the audience here. If the MAS is doubled, is the dose doubled? Who is saying yes to this question? Only one person. Who is saying no? Who is not quite sure and who doesn't particularly care? I only saw one person answer this question. The dose increases linearly with the MA. So if the scanner is on twice as long at the higher MA, then the dose goes up linearly. That's the most simplest equation that we have. So we need to reduce the MA and the period that the scanner is on. How about KV? If the KV is doubled, is the dose doubled as well? A little bit more difficult. We know that the spectrum that comes out of the X-ray tube has varying intensities and energies. And if the KV goes up, not only does the average energy of the beam goes up, but also the total amount of radiation goes up. So we have to lower the MA accordingly in order to still get an adequate dose. And this is critical in plain film radiography, but in CT, no matter how much dose you give, you get an excellent image anyway. So dose and KV, there's not a simple relationship. If the KV goes up, it goes by the square root up. If the pitch is doubled, what happens to the dose? Is it doubled, cut in half, same? You can see that on this illustration. If the pitch, the table speed is twice as fast, the radiation dose will go down, both the absorbed dose in the organs and also the effective dose, the dose length product. So we have to use a high pitch factor and scan the patients as fast as we can in order to lower the dose. What about the longitudinal coverage? How does it affect the dose? Is it doubled? Will the dose be doubled? And the answer to this question depends on what you define with dose. If it's just the dose in a particular organ that's in the primary beam, it does not make any difference. But if it's the total organ, the total body dose, the dose length product that correlates with the effective dose, then indeed, if the scan length goes up twice, then the effective dose goes up twice too. So we have to make sure that we cover as little as possible in order to answer the clinical question and don't overlap our sequences. What about the scanner geometry on the dose? Compared to single-slice spiral scanners, now we have multi-slice scanners. Is the dose in the multi-slice scanner higher, lower? Is it the same? And this is just a simple geometric situation. The older spiral CT scanners had a larger gantry and the patient was further away from the source. Thereby the dose tended to be slightly lower. So if you have a protocol that works for your single-slice spiral scanner, you cannot automatically transfer that to your multi-slice scanner because they may have a completely different parameter there. There's some other things that the scanner manufacturers have implemented to put bow tie filters over the source in order to cut out some radiation dose at the margins where there's less need for irradiation. And this is a very effective way to reduce the dose somewhat, but the patient has to be placed in the middle of the scanner, as is done here. Then there's a uniform output of dose all across the image. If the patient is eccentrically placed in the scanner, this effect is not optimally used, and there will be variations in dose, there will be wasted dose, and there will be more noise in the image. So the patient has to be absolutely in the middle of the scanner in order to take advantage of this effect. Z-axis modulation has been used by manufacturers, taking the principle that in the chest there is a lot of air, less X-ray attenuation, needs less dose and lower the current. In the abdomen there is less air, more soft tissues. We need to increase the MA at that point. And this is automatically done slice by slice. And Z-axis modulation has been implemented by all the manufacturers, called Auto-MA by General Electric and CareDose by Siemens. We have to specify the noise index, which is the noise in a uniform phantom. And the lower the noise index, the lower noise, and the higher the radiation dose. Another parameter to choose, it makes it even more complicated. So CT dose reduction may be a tough thing to do. There's so many things to look at. We want to lower the dose, but do we accept more noise? Get more streak-eyed effects? There's always the balance between image quality and radiation risk, and we don't want to only look at one side of the equation, the radiation risk. We also want to look at image quality and make sure that our images remain diagnostic. So that's what we try to do in our hospital. We have tailored the dose to the patient's size, and we have color-coded protocols in place where we look at the various weight groups, babies, cuties, kiddies, and teenies, based on weights. And then we have specified the noise index that the scanner prescribes. We have maximized the MA, so we'll never go above that level. And we've also adapted the KV to the body size. And this is the pink protocol, which is the standard protocol that we use. And if patients had prior CTs, we can do a green protocol. And if they have many prior CTs or specific indications such as musculoskeletal work, we can do an ultra-low dose CT protocol with different parameters. It's all protocolized, it's all easy, it's implemented in the scanner, so there's no guesswork involved. We even looked at special indications for high-dose studies, subtle liver lesions. We use a higher dose exam, kidney stones, very low dose exam, and then CT angiography. We prescribe the optimal dose parameters as well. How is this going in real practice? A doctor orders a CT scan, it's input in the computer, the radiology resident looks at the clinical indication, a number of prior CT scans that were done, and then decides on a zone, in this case the red zone. This is also implemented in the computer. The technologist reads and realizes there's a child there on the table. Then the child will be weighed, and then automatically, by hitting the right protocol, the regular protocol comes up based on what we have programmed in the scanner already. So there's very little guesswork involved. It's an automatic process, which reduces the errors that can be made in this difficult, complicated situation. What does it look like in real life? Perforated appendix, pink zone, standard protocol. For the follow-up study, a noisier scan, but still diagnostic. And you can see it in the coronal view as well. It's definitely noisier for the follow-up, but more than 50% radiation dose reduction. And if we have to do another follow-up in that same patient, we may even lower the dose further by reducing the scan length, and we can scan the patient in the red protocol, the ultra-low dose protocol. So it's a team effort. We have protocols, we have shielding of the breast, we have measurements of radiation exposure on the skin, which I have done in a number of patients for cardiac CT, the highest dose study. And this is probably the most important slide of my whole presentation. It's a child referred for cardiac CT. And this makes me realize, this very opaque letters on this patient's T-shirt, that parents every day trust their children to us with the care and assume that we will do the right thing. And so I have been trying to measure this on the patient itself with these dosimeters and came up with some interesting observations. This young child, cardiac CT with a very low radiation exposure. The skin dose was measured by me, 1.2 milligray. The breast dose is known to me, 1 mammogram approximately, short DLP and a very low effective dose. Diagnostic information that is very helpful to cardiologists, VSDs, patency of the pulmonary vein, and pulmonary hypertension. And a young infant, 6-day-old, with pulmonary atresia, diagnostic CT scan with multiple aortopulmonary collaterals, very low exposure with no cardiac gating used for this indication, only 2 mammograms worth of skin dose, 1.6 millisievert, and a completely diagnostic exam. So we don't have to get beautiful images, we just need to get the diagnostic images here. Another patient, a slightly larger child, 7-year-old, sinus venosus ASD repair with a superior vena cava is anastomosed with the right atrial appendage, and we found that the anastomosis was wide open. However, there was still, after this surgery, abnormal direction of flow from the pulmonary vein into the right atrium and also into the left atrium as it should be. So this patient required another operation. Completely diagnostic information here in a very easy exam. And then cardiac coronary CT, this is one of our earlier studies. In an overweight child with atypical chest pain, 25 mammograms worth of radiation dose. Now we do prospective cardiac triggering, which lowers the radiation dose substantially and has still a diagnostic image quality. So we tailor the pediatric exam to the clinical indication. What is the clinical question? What is the required longitudinal coverage? What is the anatomic region? Skeleton, chest, abdomen, they all require different exposures. What is the body size and how much noise can we accept in the images? Are we looking at gross anatomic features, follow-up of a lung abscess, or do we need high contrast resolution in the liver? And what are the requirements for slice thickness? Do we have to do 3Ds or something like that? Then we use in multi-detector CT the full beam width, thickness, the radiation pro width, and use all the detectors for image reconstruction. Use the highest stable speed possible, the fastest tube rotation, lower the KV whenever possible, and use longitudinal dose adjustment. Pick the appropriate noise index according to what I have shown you in our protocols. So, my take-home message, acknowledge the individual and population risks of CT radiation. I wouldn't use the word low-dose CT. We try to reduce the dose, but it continues to be a relatively high-dose exam compared to many other studies we do. Use CT as a confirmatory test of known disease when there are treatment implications. 1 CT equals 400 chest X-rays, 8 mammograms, 10 abdominal X-rays, and 3 years in background radiation, and perhaps 4,000 tablespoons of peanut butter. Keep looking at the big picture. You know, we are, as radiologists, involved with looking at many images. We have to look at all these technical parameters. We have to answer all these questions. But I hope that you can take some of this information to your own practices and implement it so that it may benefit your patient and that you can continue to look at the big picture as I try to do in this presentation. Thank you very much for your attention.